the joint itself and in the extra articulations, like the AC joint in particular. There's a crepitus related to one or both of those areas. One of the things that you wind up with a lot in shoulder injury is impingement injuries. If you recall, you've got the acromion right here and the clavicle right there. Then right up underneath that, that's where the supraspinatus tendon is going to run, and that's also where the tendon of the long head of the biceps runs. It's under the AC joint or the acromion. So impingement syndromes is an inflammatory process in the shoulder that when you move the shoulder, it impinges on those tendons and causes pain or actually decreased range of motion. The elbow carrying angle is, I don't think I've ever documented the carrying angle on a person, but if you look at a person standing there, you'll notice the elbow is not 180 degrees. There is a slight 10 to 30 degree angle normally of the elbow. That's called the carrying angle if you ever see that. Epitrochlear nodes, you remember the lymphadenopathy when you're dealing with the lymphatic system above the trochlear processes on the humerus is where you'll find the epitrochlear nodes. The wrist, examination of the wrist, in addition to range of motion, so full extension, full flexion, radial deviation, ulnar deviation. Those are the rotations, those are the range of motions of the wrist. The two symptoms for median nerve entrapment are Tinel's sign and Phelan's sign. Tinel's sign is when you take the wrist, if a person comes in complaining of carpal tunnel syndrome. Carpal tunnel syndrome we went through in anatomy would be paresthesias on these 3.5 fingers, weakness of the thenar eminence, weakness in these fingers, usually due to a repetitive motion process. You supinate the forearm or the upper extremity. You hyperextend the wrist and you tap right here over the median nerve. And if there is swelling in the cubital tunnel, when you do that, it will send flames of shock-like sensations down into the distribution of the median nerve. That's Tinel's sign. Phelan's sign is when you have them sitting here, you have them put their hands like this in full flexion, their wrist in full flexion, like this, and you with their elbows up, and you have them sit here for about 2 minutes. And if there's carpal tunnel syndrome, just this motion right here puts a lot of pressure on the carpal tunnel. They'll wind up, start telling you that their fingers are tingling, and it's uncomfortable. So Tinel's and Phelan's reproduces the symptoms. It should reproduce the symptoms. A lot of these tests should reproduce the symptoms. Going back to Ruth's test for the thoracic outlet reproduces the symptoms. The other tests that I showed you don't reproduce the symptoms, but there's a finding. So there's a difference between the types of tests that you do. Okay. The hand, we did Finkelstein's test in anatomy, which is you just take the thumb and if a person complains of pain in this area of the wrist or forearm and thumb, they happen to be a school teacher, and she's these staples. She's using a staple gun several times a day, or if they're in construction, using some type of staple gun, and you wind up with a tendonitis of the thenar muscles. Finkelstein's test is a test for, what's the test for? Anybody remember? That's an odd name. De Quervain's tenosynovitis. You had it in anatomy. Okay, you had it in anatomy. I told you, you have to remember everything I ever say. Okay? De Quervain's tenosynovitis. And Finkelstein's test is you put your thumb in your palm like this, wrap your other fingers around it, and you ulnar flex your wrist. And that produces stretch on the tendon and reproduces the symptoms. Finkelstein. If you do that on rotation, if you tell your preceptor, oh, Finkelstein's test was negative, they will think you're a rock star, okay? Bouchard's nodes and Heberting's nodes, these are osteophytes, or they're overgrowths of bone related to arthritis. You see them on this illustration here. Bouchard's nodes affect the PIP of the fingers. And you see them right there on X-ray. You see them as swelling of the PIP joints here. Heberting's nodes affect the DIP. They're related to osteoarthritis and rheumatoid arthritis. Heberting's nodes affect the DIP. You see the swelling, the nodularity out here. The easy way to remember that is B comes before H. So from proximal to distal. Bouchard's and Heberting's nodes. You also get with arthritis ulnar deviation of the medial 4 digits. The longer it goes on, the more this deviation presents. You can see it like that. They don't have a lot of dysfunction related to the deformity. This would be an example of deformity that you're noting on your note. But they do have a lot of weakness related to it because of the change in orientation of the tendons. Okay? I think some of our SPs, if you'll pay attention, they have some ulnar deviation, not to this extreme, but they have some ulnar deviation in their hands. Okay? Lower extremity inspection. One of the things you want to make sure you note on inspection is, particularly in the population here in Oklahoma, since everybody has diabetes, is the presence or absence of hair on your toes and on the leg. Now, if you shave, that's okay, but you should note the presence of hair on the toes. In diabetes, because of the neurovascular issues, the hair follicles are poorly, they don't receive enough blood, and they eventually just die off. So if you look, even on females, can you take your shoe off? Even if you look on females, oh God, look at see all the hair right there? So even on petite females, they have like gorilla toes. So make sure you note that. The hip, the rotation of the hip is essentially range of motion. So the different ranges of motion of the hip, we'll demonstrate them later on, but again, are going to be flexion, extension, abduction, adduction, and rotation. Internal rotation and external rotation of the hip. Trendelenburg sign we went over in anatomy. Remember, weakness of the gluteus muscle, particularly the gluteus medius, produces an unstable hip, essentially. So you wind up, you lose the ability to keep your pelvis centered over your hip during gait. Ordinarily, when you raise your leg, you should be able to maintain pretty much a horizontal pelvis, not quite horizontal, but pretty much. But in gluteal muscle weakness, you essentially have to park the pelvis over the the femoral head before you can lift the other foot. Okay? The knee, there are tons of signs here or tests. We'll do them when we get there on the physical exam. These are all the different ones that you should be able to do. The ankle, there's one specific, well, there's one test of the ankle and one test of the foot that I want you to know. The drawer test of the ankle, just I'll demonstrate it later on, is essentially you're just looking for the mobility of the ankle mortise, the joint itself. Okay? This is from the neuro lecture where I went over strength 0 to 5. You know, if you on your screening exam, if everything is symmetric and everything is appropriate for your development in age, you can state, you know, muscle strength in the upper and lower extremities 5/5. And that pretty much tells you everything you need to know. Bilaterally, everything you need to know. Now, individual muscle groups, we went over this in neuro, but you need to pay attention to this because if there is muscle weakness, you need to break it down to the muscle group and the nerve that innervates it. And that's what this does. When you get down to the feet, to the hands, looking at specific intrinsic muscles of the hands are important. Grip strength, abduction and adduction are important. Your thumb and your little finger testing the thenar and hypothenar eminences is important. And I went over that in neuro. The lower extremity is the same thing in large groups. Where you're testing the femoral nerve, the sciatic nerve, the common peroneal, the deep peroneal, the superficial peroneal, and these address that. Any questions about any of that? Okay, so let's change gears just a little bit here. Okay, so this is not a PowerPoint, this is just a Word document. What I say in the top 2 paragraphs are, when you're looking at the musculoskeletal system, there are 2 ways to approach it. One is you're doing a screening exam, like the older person who's a new patient to your practice, you want to get a feel for their level of ability or disability, or the athlete, or the worker, if you're doing an employment physical, can the person do the tasks that are going to be assigned to them? Versus the second paragraph there is a focus exam on a specific joint due to injury or a complaint in a specific area. If I come in saying, you know, I've been playing a lot of golf lately, and I have a bad pain right here, you do not need to do a knee exam, okay? What you do need to do, though, is an exam not just of the elbow, but I would look at it as a joint above and a joint below. My wife has this jacked up ankle. She was in a car wreck when she was 18 and just destroyed her ankle. So they put it back together, but she has this horrible, if you ever watch my wife walk, she walks on the side of her foot. I don't even know how she walks, to tell you the truth. But recently, over the past couple of months, she's going to have it fused later this fall. But over the past couple of months, she's been complaining of this horrible hip pain. There's nothing wrong with her hip. It's her foot causing her hip pain because she walks. She's externally rotating her hip. Her foot has now impacted her hip. So you need to explore not just one joint, but essentially, when I say one above and below, I'm telling you, you need to look at the limb. If it's an appendicular problem, you need to look at the limb. Okay? So, screening exam, if we scroll down here, if we look at the screening exam, this is the stuff that I mentioned to you before. And there's the spine, and then we get into the upper extremities, our inspection, our palpation. There's the statement about consistent with development and age. And there are the elements, specifically strength, vascular, and neuro. Now on neuro, proprioception, remember going back to the neuro exam, you take the finger and the great toe, move it up or down. Is it pointing up or down? That's all you need to do. Sensation with sharp or dull is with a Q-tip or some device like that, and then vibration. We've done that with the neuro exam. I want you to do it here. Okay? So in the SPVL, you're going to do the neuro elements of that. If it's an elbow issue, I want you doing proprioception. I want you assessing the neurological status of that limb. And the only way to do that is with strength and sensation testing. You do the same thing in the lower extremities. Okay? Same type of thing. So, let's do, just kind of run through a screening exam. Okay? Now, I didn't bring any of my neuro stuff down here, so I'm going to leave out sensation and vibration, but remember, put it in here. You look like a sporty young fellow. Get yourself on up here. Okay? So if you just sit right there on the table with your knees pointing this way and remove your hand. Okay? So as you approach the patient, I'm inspecting his, can we take off, you got a t-shirt on underneath? Yeah. So I'm inspecting the patient, starting with the cervical area, and I'm palpating just for symmetry. Touch your chin to your chest. Look up at the ceiling. Can you turn around and look at the wall over there? Can you turn around the other way and look at the wall? Can you take your ear and touch your shoulder? Can you touch it to the other side? That's the range of motion of the cervical spine. Now, if there was a complaint, then I would test it, I would do those same motions with resistance. If I'm just screening an exam, I don't need to do resistance here. But if his complaint is something, a stiff neck, or a strain because he was lifting something, then you're going to do it against resistance. Push back against my hand, pull forward against my hand, turn your head against my hand, turn your hand like that, right? But that's a special test. Just checking the range of motion is not. Okay, now, the other thing about the thoracic spine and the lumbar spine, I'm going to do with him standing up. But I'm not going to get him from here to stand up and do that, and then have him sit back down and go back and forth 100 times. So I'm just going to go straight to the upper extremity, okay? Now, again, it's palpation, inspection, and palpation. If he had a complaint, I'd be looking at the skin. If I'm just screening, I'm not. So I'm just feeling, just generally feeling along here. No big issue. Can you take your arms straight up? Okay, wrap them like that. Go around behind back. Okay. Can you do like this? Go down as far as you can. Do the other arm. Down as far as you can. Okay. Rock to the side. Straight up. Like that. Okay. Full range of motion of your shoulders. Take your elbows and do like that. All the way up. all the way in, all the way up. Do like that. 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 Wide open. Do like that. Touch your thing like that. Okay, there you go. I have done the range of motion of every joint in his upper extremity. If there was a complaint, then I'm going to assess it related to strength against resistance, right? Now, before I finish here, and during part of the exam, because you would have done this in the peripheral vascular exam if you're doing a full H&P. But if you're not doing a full H&P, if you're doing a screening musculoskeletal exam, I'm going to check his pulses in both radial and ulnar. And put your fingers like this. I'm going to take your finger, I'm going to have it pointing up or down. Right? Close your eye. Is that pointing up? Okay. Oops. And one way I can test the sensation is here. Put your arm straight out in front of you. Close your eyes. Touch your nose with that finger. Touch your nose with that finger. There you go. Okay? That's a very simple screening test right there. Okay? You can do the same thing with your toes. You know, if I touch your nose with that toe. Okay. So we get to the lower extremity. Now he's seated, so he's seated, so I can't do much with his hips, right? But I can go ahead and take care of his, from his knees down. Can you extend your knees? Okay, back down. So his knees your knee range of motion is greater than 90 degrees. It's like 140 degrees. It's greater than 90. I have to finish that flexion while he's supine. So right now I just have him at 90. Okay, you got to keep that in mind. Okay, feet up. No, just bend your knees. Let your now ankles up. All the way down. Turn them in. Turn them out. Toe up. Big toe up. Big toe down. Okay. I come down here and I do his dorsalis pedis, his posterior tibialis on both sides. And as I'm doing this, go ahead and note the hair pattern. He's got nice hair on his toes and everything here. Temperature is appropriate, right? And then you can do the proprioception in his great toe. Okay? Go ahead and lie back for me here. So during you might scoot back just a little bit. Yes, maybe we should get a short person. So we still got to get his hip, right? Now I'm not going to, make sure when you're doing your exam, they only lie down once. Chickens lay, so they only lie down one time, right? You don't have them back and forth, back and forth. So I'm going to go ahead and get you to take this, pull it all the way up, bring your leg all the way up. So there's his hip and there's his knee, right there. Rotate it in, rotate it out, okay? And do the other side. Same thing, up, in, out, okay. Straight, right, straight. Okay, all right. You can sit up for me. Now stand up. All right, so while he's standing up, as part of the neuro exam, I'm going to get you to walk over to the door. Walk back heel to toe. Turn around, walk back heel to toe. All right, so remember I told you during the neuro element that you combine a lot of neuro and musculoskeletal at the same. I just tested gait. Gait is a function of the musculoskeletal system, but obviously it's a function of the nervous system as well. Okay? Put your toes and heels together. No, right, side by side. Arms straight out to the side. Close your eyes. So you can open your eyes. Open your eyes. Put your hands down. Stand up on one foot for me. Hop up and down. Stand on the other foot. Hop up and down. What am I doing here? I'm testing strength in his lower extremities, right? Okay. Bend around and touch. Turn around, face the wall, and bend down and touch toes. And slowly come back up. Okay, good. For his scoliosis right here, I grab his pelvis, which has been, and I would lean back because it's amazing how much these, like a dancer, how far they can bend back. Lean back toward them. Lean back toward them. Stand up straight. Okay. Take this hand and slide it down your thigh, as far as you can go. Slide it all the way down. Go to the other side. So that's lateral bending, right? Stabilize, turn around, look at me. As far as you can. Go. Turn around the other way. That's your truncal rotation that I was talking about earlier, right? Okay. You can have a seat. That's a screening exam.
Go over there.
Huh?
I can go back over there, stay here.
No, stay right there. If you have an athlete or you really want to test function of the lower extremities, stand right here. You know what a duck walk is? Bend down, bend down, bend down. The way down. Now come towards me. If you can do that, there is nothing wrong with your hips, your knees, your feet. You are neurovascularly and musculoskeletally intact. But you cannot get our SPs to do that. But if you're like if you go with Lovelace in boxing, or if you do a high school sports thing, get them to duck walk, just a few steps. You've got the lower extremities right there, okay? But that's not part of the normal screening exam. Okay. Any questions about that? And it's very quick, but you have to incorporate it into the rest of the exam so they're not back and forth, sitting, standing, lying. All right, so let's talk about some special tests. Let me get a shorter person. I'll probably not get shorter. Oh, JC, come on down here. Everybody give a hand to JC as she comes out. JC's got a little bit of weirdness to her. If you'll take off your, there you go. She's got a little scoliosis in the thoracic region. So this is, so as she was facing the door right there. So this is the way I said that with him is the way you should say it. So I want you to bend down and touch your toes. All right, if you'll notice, if you'll come down, when you get to her later on, get right behind her, she's got a little scoliosis right here. Now slowly stand up. So you're looking at that spine as she stands up. Bend down and touch your toes. Come back up, slowly. See, okay, you can stand up. So that's a point I've learned in my life is when you tell them to stand up, start with the word slowly. If you say stand up, they go whoop, and you've missed it. You want them to slowly come up. So little clinical tips say slowly stand up. Okay? So you can see here, you can, if you'll bend down. Can you see it right here? There's a little bit of skull. I don't know if you can see it. Okay? All right, thank you, man. Slowly come back up there. All right.
I was just saying I can see.
Oh, yeah. And it's apparent on X-ray. You can see it on X-ray?
Yeah.
Yeah. Okay. All right, so. Oh, I didn't know it did that. Look, it changes pages. How about that? All right, focus exam. We talked about the vertebral column in terms of axial loading, and one of the tests for thoracic outlet syndrome is labeled there. Upper extremity, we've got the empty and the full can test, and that is for injury to the supraspinatus. Now, I almost did it all wrong here. Go ahead and put your arm out again, 45 degrees, like that. So put your fist together, put your thumb up. That's the full can test. You're holding the can up. So push up against my arm, against resistance. That would be painful. The empty can test is you pronate it. Now push up. Okay, so it's like you pour it out a can versus a full can. That's for supraspinatus. Near's test is basically, let's get, Abby, come on down here. No, you have a dress on. No, you have shorts on. Yeah, that's perfect. Yeah. Okay. Near's test is you're sitting right here, And what we're gonna do is, this is one of the tests for impingement. These three tests here, Hawkins, it's also called Hawkins-Kennedy test, and the crossover sign is for impingement here. Mears test is really easy. All you gotta do is you take the arm, straighten it out, and just pull it up quickly like that, so that the arm, it comes up next to the ear. You don't want to do it like that. You go straight up. So that will cause pain in this region here. Okay? Hawkins test is pretty much the same thing. We're just doing it a little different here. Hawkins test, you have the shoulder flexed to 90 degrees. You have the elbow flexed to 90 degrees. And now what I want you to do is I want you to push up against my hand. Okay? The second thing is I'm going to take your arm and rotate it in like this. And that would produce pain up in this area. That's the Hawkins test. Now, what you want to prevent them from doing is leaning away from the test. You want them to stay straight up and down and rotate the arm like that. Rotate the arm in the shoulder. Okay? Crossover is you basically are just taking your hand, putting it behind their shoulder, and running their upper extremity across their chest. This produces pain if there's an impingement problem. Okay? What we have next is we have the labrum grind test. This is interesting. Go ahead and lie back for me there. Can you scoot up just a little bit? So basically with the labrum grind test is you're going to take the arm and extend it, right? You're abducting it, really, is what you're doing. You're going to take the elbow like this and push this way. You might have to have somebody over here. Some people will put their hip on it like that. What you're doing is you're grinding the head of the humerus into the labrum. That's called the grind test. If there's a labrum tear, like from a dislocated shoulder, this is a very common finding with a dislocated shoulder, it will produce pain. There's also a grind test in the meniscus down here as well that we'll talk about in a minute. Okay? All right, sit up on here. All right. The elbow, again, those are all self-explanatory there. The wrist, we've already been through, and the phalanges, we've been through. Is that the come on in. We're almost there.
The table's in your way.
Oh, okay. Well, that's fine. We're almost there. All right. Any questions about the upper extremity, special testing wise? Okay. The lower extremity, I don't want to do you. Andrew, you? Yeah, come on up here. And go ahead and, so SI joint stability. Go ahead and lie back. So basically what you're doing on, I don't know what about this table, the SI joint stability is basically you're going to put your hands on the anterior superior iliac spines, right there, and push downward. And try to rotate this pelvis in and out. Okay? Ordinarily, you're not going to move it very much, but if you have somebody with inflammatory process going on with the SI joint, ankylosing spondylitis, or anything like that, it's going to be quite painful to try to manipulate the pelvis in that manner. Okay? The piriformis sign is, the piriformis muscle remember, comes out of the greater sciatic notch and attaches to the head of the femur here. What you want to do is you want to put stretch on that. And piriformis tendonitis is common. So what you want to do is you want to flex the leg like this and take the knee and bend it to the opposite shoulder. So you want to rotate it to the opposite shoulder like that. That is putting stretch on his piriformis muscle. Do you have a problem with the piriformis? Yeah, and this would light you up, wouldn't it?
Oh, it hurts really bad.
Yeah, let's get her down here. Everybody wants to see her. All right. What do we have? Is greater sciatic notch, if you'll sit up for me. Greater sciatic notch, is feet down. It's basically when a person has a sciatica, right? The greater sciatic notch is where the sciatic nerve is exiting. So what you do is you tell them, I'm going to press on your butt here. I'm not trying to get fresh or anything. I'm just pressing on a particular spot on your butt. Is you take, so he's sitting on his ischial tuberosity, right? The greater sciatic notch comes up from that. So what you do, you take your fingers like that and just push right there, where is right above his ischial tuberosity on both sides. Just push in there like that. Is that tender? If they have sciatica, that will light them up. Have you had that problem as well? Yeah. So palpate, putting firm pressure on the sciatic notch is the way to go there. The straight leg raise test is a good test for sciatica, but also it's a good test for malingering with back pain. And I may have gone over this in anatomy. I think I did. So if he's complaining of back pain, or so when you're dealing with back pain, if you go back to the HPI, does it radiate? Does it go down into your butt or go down into your leg? If it goes down into your leg, you ask them where in their leg. Is it in the posterior leg, which is sciatic? Is it in the anterior leg, which is femoral? If it's sciatic, if they're complaining of back pain and radiation down the anterior part of the leg, then that's a little odd. Okay, it really shouldn't do that. Okay, so what we're going to do here is we're just going to raise the leg up. Now his hip is at 90 degrees relative to his vertebral column. If he has sciatica, that's going to be painful. If he has true back pain, that's going to be painful. Go ahead and lie back. There you go. So you repeat the same thing, you repeat the test with the patient lying, supine. So elevating his hip like this, look at the angle. If he had no pain sitting, he should have no pain at that angle. If he had pain sitting, as I start to elevate his lower extremity, it's going to be painful. And you do this passively, not actively, both sitting and supine. If he was negative sitting and he's positive supine, more than likely, it's not real. Okay? It should be positive, both sitting and supine. And that's how you note it, you record it. Straight leg raise test positive on the right, sitting and supine. Okay, you can sit up. Trendelenburg sign, we talked about. In leg length, if they're having back problems, take a second to measure the leg length from the ASIS to the medial malleolus. It's amazing how much people are asymmetric in that regard. Okay? Not that you're going to do a lot about it, but it could be the cause of that back pain. All right, now we get down to the knee. And we have a kind of knee model here, but let me start out on Andrew. And Jordan has some looseness as well, so we'll get her down here and play around with her as well. Start with the anterior and posterior dorsine and Lachman's test are very similar. They're both looking at the cruciates. The cruciates, of course, prevent the forward and posterior displacement of the tibia on the femur. So the anterior posterior door test is, with you sitting here, you grab the knee I grab lower down on the leg and use my left hand to push the knee back. And if you look right here, there's a couple of millimeters of movement posteriorly. And then if I get behind, I switch my hand positioning, get behind the calf up here and pull out, I can pull out his tibia just a little bit. You see that? Just a little bit. And it should be symmetrical on side to side. That's the anterior and posterior drawer side. Now, a lot of people, go ahead and lie back and scoot back. Some people will do this by, now, when he's sitting there, his knee is flexed to 90 degrees. Some people will flex the knee right here to 90 degrees, and they can do an anterior and a posterior drawer sign with them supine. It doesn't make any difference which one you do. But this is what I don't want you to do. Some people teach it this way, and it's just stupid. They'll say to sit on their, to stabilize their foot by sitting on their foot. Don't put your big ass on somebody's foot. You don't need to do that. Just hold their ankle there and do the test that way. I don't ever want to see you put your butt on it. They actually teach that. Don't do that. Don't ever do that. That's stupid. Why don't you just have a bowel movement? The other test here, Lockman's test, is you only have the knee in 20 degrees of flexion, not 90 degrees. That's the only difference between the two. Okay? Not that one's, I don't think, any more specific than the other. It's just, you know, if you have a knee issue, you may not be able to get your knee into 90 degrees of flexion. Okay?
And it's more comfortable laying down rather than dangling down too, so whatever's better for your patient
There you go.
as far as their pain.
Okay, Apley's, well, let's save Apley's. Let's go, McMurray's test is, I love this test because this is the one I want you to practice on with each other. I'm going to take your shoe off here. So McMurray's test, what you do with this is you're testing, so you have a medial and lateral collateral ligament and you have a medial and lateral cartilage. You're going to test those four. So I'm going to get you to bend your knee. And now I'm going to rotate your foot in. I'm going to rotate your knee out. And what I'm going to do now is I'm going to bind your knee and extend it. You see, I have pressure on his knee. The knee is locked here. So what I'm doing, if you look at it here, I'm stretching his lateral collateral and I'm grinding the medial meniscus into itself. So, is that painful? No. And I come back up and I do it the opposite direction. I externally rotate his foot, internally rotate his knee, and then I'm pushing it. You see how much tension is on his knee there? So now I'm stretching the medial collateral and grinding the lateral meniscus. And finally, I go up one more time. One of the problems a lot of people have is patellar tracking. The patella doesn't track in between the condyles of the femur, okay? Osteomalacia patella is when the back of the patella starts getting arthritic and not smooth. People, when they walk up and down stairs, it's painful. There are two retinacula that keep the patella tracking normally. There's a medial and a lateral retinaculum. The lateral one is more tight than the medial one. And sometimes it will pull the patella laterally, and people have patellofemoral syndrome. Patellofemoral syndrome is either due to tracking or osteomalacia. Okay, most of the time. So we're gonna simulate tracking by flexing his knee. I'm going to grab the medial patella and pull it laterally, like that, as I extend his knee. Does that hurt? So I'm artificially pulling it laterally. The treatment for it, when you get in orthopedic surgery, is they'll do what's called a lateral retinacular release. They go in and cut the lateral retinaculum that moves the patella more normally. The medial is not strong enough to pull it too far medial. Okay? So that McMurray's with that patellar tracking test. Ballottement is with the knee, with the lower extremity extended. If you have effusion in there, in the space, in the joint space, the patella will float or essentially rise to the top of the fluid. When you push down on the patella, you'll push it down through the fluid, and it'll feel like a sponge floating on the top of water. That's patellar ballottement. It signifies an effusion in the knee. All right. Valgus versus varus strain. Valgus is when the knee, the legs are deviated laterally, like that, like knock-kneed. Varus would be like cowboys. So what you do is you're testing for the collateral ligaments by just simply taking the leg while it's straight, the lower extremity while it's straight, and putting pressure, medial and lateral pressure on those collateral ligaments. Okay? And finally, Apley's test. Go ahead and roll in some. Apley's test. You got to remember that if it's his left knee that he came in on, when he rolls over, the left knee is now over there. So don't. You got to go to the other side. Okay? I've done that before. Like done Apley's test. Does this hurt? No, but that's my good knee. Oh yeah, I know that. So.
Just check to see if you're lying, didn't you?
Yeah. So what you do with Apley's test is, so his femur is there, and his tibia is right here. So his tibia is sitting on his femoral condyles right now. And between the two are going to be the menisci, right? This is a grind test. And some people just do it with their hand, but I like to really get after it. I like to put my weight on them like that, push down, and as you do that, you rotate the tibia on the femur. And if you've got a meniscal tear or any type of feathering to the meniscus, that will light them up. Okay? That's Apley's test. Okay? You can sit up. Any questions about any of that? And finally, for the ankle and foot, the two tests, it's a drawer test, just like the knee. What you do is you take your hand and you cup the heel like that, and the anterior talofibular ligament prevents the anterior displacement of the foot. So you grab the lower extremity and you try to pull the foot forward. It's just an anterior drawer sign. There's no posterior here. You just pull the ankle forward. And if you come in, I mean, you can see, you can feel the movement. He's got a little crepitus actually in his ankle there. You can feel that. And finally, the MP compression test here is you take your hand and just grab their the metatarsals here at the heads, the MP joint area, and you squeeze them. You're just squeezing the foot, and you can even rotate it inward and outward. Arthritis that's not going to be very pleasant.
Gout, that will flare up their gout.
Yeah.
Or the gout starting to hurt.
Yeah, you won't get very far with if they're gout. So, okay. Any questions about the special test? Okay. So what do you got going on here?
I have a complete ACL tear, and then I also have a posterior tibial tendon inflammation, which is in my ankle.
Okay.
So
So can you take that off or not? All right, so it's not a, because she's conscious, we're not gonna be able to yank on, when's your surgery? Thursday, for her ACL repair. So what we wanna do is if we're looking at her knee, she's got shorts on, so we're, okay. So if we're looking at her knee, you know, just inspecting it, if you need to come down further, you can. The one thing that I noticed right offhand is that the carrying angle of her knees are not the same. This one's hanging straight down, she's got this one forward a little bit. It's forward because of pain or swelling or whatever, but there's asymmetry. There's also asymmetry, you can tell there's some bruising right in here. If you look at the contours of her knee, looking at the shadows here, you can see how that goes in right there, but that's full right there, you see that? This goes in below her patella, but that's full right there. Okay? One thing about joints is when you're assessing them, it's always a good idea to start with the normal joint. That way you've got something to compare to. So over here, if it's her anterior cruciate, so you would expect her to have a positive drawer sign, right? So if I come over here to her good leg, and I get behind here, and I pull forward, you see there's pretty good stability. You see there's a tiny bit of movement, just a millimeter maybe or two, okay? Posterior, you see the little movement there? There's a little bit of movement, okay? I don't know how much more lax yours are, but if we come over here, it's pretty sensitive.
I haven't had it tested since Monday, so.
Oh yeah, you see it, it's crazy. That board is on freaky. You see how much I can move that forward? Hey, you do it. You do it. Have a seat. Have a seat. I'm gonna go throw up.
Haven't hurt at all today. Been icing it and preparing. Can you feel it? I can feel it. It doesn't hurt at all.
Go ahead, go ahead.
Way to tell your patient to relax because it doesn't work if they're guarding.
Yeah, that's another thing throughout the exam. If it's hurting and they're guarding, you're not going to get a good exam. But understand that, and don't push it.
Stick your thumb right there, so that if you put your thumb right at the junction, you'll be able to tell the movement of one bone on top of the other. Feel the bottom one move out from underneath the femur.
Oh, yeah.
I'm lateral.
Have a seat over here.
I also have a lot of growth.
Mine's more lateral collateral.
This one?
Yeah, please.
Doesn't hurt me. Jump in. I'll tell you when it starts hurting. Be really firm and put your hand on my ankle to control the back so that doesn't move.
Also, poor Jordan here, look how much movement she's got in her lateral to lateral. I mean, that's almost retarded. Go ahead and do it.
Yeah. Yeah, like that.
It doesn't hurt, so.
You're getting to hit your professor. I got my medial lateral one also is loose. Dr. McNeil, do you want to see if my medial collateral is too? It was earlier. That's why I thought it was more like this.
Yeah, you can, like, put your hand more right here.
Can I do this? Yeah. The first one.
I know we can
Can you feel it?
Like I've spent a lot of time with this, I've spent no time with this. So I think this is really fun. I feel like I like most of the time I'll just and it's like the way she asks the question. She's giving you a keyword or something. Very bland.
Professor Polk is starting here at 10 o'clock.
I'm gonna not.